I'm talking to Dr. Frank Martin about this new program from JDRF. Really caught our attention and wanted to learn more about it. Dr. Martin, thanks for joining me.
Oh, thanks very much, Stacy. It's good to be here.
Yeah, so tell me a little bit, just in general, about T1Detect. I think a lot of people saw it pop up on social media, got it in an email from JDRF. What is it?
So it's, first off, something we at JDRF are very proud of. Our mission is really around accelerating the development of disease-modifying therapies to help slow, cure, or prevent T1D. And towards that, we saw that there was a gap. There was a need to be able to identify more people who might most benefit from therapies like that. And right now, there's a lot of great programs, a lot of great research programs that are doing this. Places like TrialNet, the ASK program in Colorado. There's a lot in Europe as well. But those programs still aren't identifying enough people. So how do we identify more people? We knew that we need to educate more people about what it means to be at risk for T1D, that it's not just family members who are at risk, but I think it's almost 85% of people who are diagnosed that don't have a family connection. We need to be able to teach the general population, teach the United States and hopefully the world that this is a real issue. And so T1Detect really is an education program, an awareness program about type 1 diabetes and its risks. And then a very important component of that is making the test available to people. Because right now they're not really available to people except in the context of research settings, or as people like you might know, in the context of an actual T1D diagnosis. Right. When someone's has super high blood sugar, they're in the hospital, and then the doctors will do a confirmation test to see if it's type 1. We want to make it available to people who don't yet have symptoms. So hence T1Detect.
All right, so tell me about how it works. It looks like you get something in the mail. Tell me about the test, like the physicality of it.
Sure. So you can go and find the test in a couple different places. First and foremost is the JDRF website. We have access to information and the test kit button on our website through T1Detect. You click the button, it gives you some information about what it is to have T1D, what the risk factors are, what are autoantibodies, because remember, what are we testing for? We're testing for autoantibodies. One of the major signs and symptoms that people have the autoimmunity that leads to T1D. You click the button, you go to the Enable portal. Enable is the company that's running the test for us. Fill in some information. We're asking for your name, mailing address, things like that. We're also asking for some demographic information. We want to learn who's getting T1D, who's at risk, and that'll help us improve the program going forward. And then you come to a choice where you can pay for the test. The test is not terribly expensive. It's $55 to run the test, plus or minus a couple taxes. You also have the option, if you cannot afford the test, to have JDRF pay for the test for you. We'll pay for the bulk of the cost, leaving you with just a copay, $10. Right now, it's not a feature to ask your insurance company to pay for this, but in the future, it will be. So all that being done, the test will get sent to you. You'll get a little box in the mail. And it was pretty simple. I did it. You have a lancet, you take a blood, you poke your finger, and then you fill in 2 out of 4 of these circles on a piece of cardboard. Let that dry and send it back. And then a couple weeks later, the company will tell you, do you have 1, 2, or 3 of the type 1 diabetes specific autoantibodies.
All right, so let me just stop you right there. It's a finger stick. You guys are providing the lancet in the envelope.
And the Band-Aid and the gauze. It wasn't very hard. There's a little bit of milking involved to get the blood, but it wasn't a lot of blood.
Well, I'm laughing because it's, when we do a finger stick, right, you have to have clean finger, all that kind of stuff. It doesn't really matter, or there's instructions.
Okay, so that's part of it too.
Okay.
Yeah. So I wash my hands first. There's a little alcohol swab to sterilize my finger, and then I did the test. But one of the benefits of what we're testing for, it's sort of a little resistant to dirt and contaminants.
Yeah, I would think so. You're at home. You're not in a sterile lab.
Yeah.
So it's been okay.
The reason we partnered with Enable Biosciences on this particular test kit was because they've tested it a lot in this situation and shown that when it's performed at home, and I have dogs, there's dog hair in my house, there's all sorts of crazy things going on in your house, it still met the sensitivity and specificity requirements that we would need to say, yes or no, you have the presence of this marker. So we have some pretty good confidence in the validity of the test in that regard.
Got it. I have a lot of questions.
Sure.
My first is, and we're going to talk more about the test itself and what you're testing for and what you do with the results. But I have to say, my first question is, if you're looking for people who are not touched by type 1 already, right? You want people who don't have it in their families. I have to say, I'm not sure JDRF, I didn't even know what that was, right? Before diabetes. Why not reach into pediatricians' offices or other organizations, or is this coming?
So that's a great question. So I have two answers. First is, yeah, if you don't know JDRF, if you don't know T1D, it's not going to resonate with you to see now that there's a test available to tell me about that. So there's a huge education campaign that's part of this, where we're going to educate people through social media, places like Facebook, WebMD, to tell people in the world who wouldn't normally know about T1D or JDRF what this means. That's an important component of it. The second is, how do we educate doctors who may not be familiar with T1D? Not all doctors are super familiar with it. So there's a huge healthcare provider education piece. That's also part of this program. That's why this program is not just a screening program. It's very heavily into patient education, population education, health provider education. And all those things are kicking off now. So this week, I think you'll start to see some social media campaigns around it. And in the new year, we'll be rolling out the healthcare provider education pieces. Great.
So let's get back to the test itself.
Sure.
What are you testing for? I don't know how specific you want to get, how scientific you want to get, but this is not a question of high blood glucose and that sort of thing, right?
It's not. So type 1's an autoimmune disease. You know that, I know that. Not everyone knows that. It is. And one of the ways we can tell a person has an autoimmune disease is we can look in their blood for signs and symptoms of that. Signs and symptoms that their immune system is doing something it's not supposed to be doing. In type 1 diabetes, we look for something called autoantibodies. Now, autoantibodies are something that's sort of a general term to all different autoimmune diseases. People with multiple sclerosis have autoantibodies. People with lupus have autoantibodies. What we're looking for in type 1 diabetes are autoantibodies that are specific to type 1 diabetes. And what makes them specific to type 1 diabetes is they are specific to things that are in your pancreas. So we actually are looking for 3 of the 4 primary autoantibodies that have been determined through many, many years of research to be very good diagnostics for type 1 diabetes. They're IAA, IA2, and GAD65. Some people may remember those names from TrialNet or other organizations, but they're 3 of the 4 that help us diagnose T1D and predict your risk. Now, we're not doing the 4th, but we will soon do the 4th. Okay. But based on those 3, if you have 2 or more of those, we know pretty well that your risk of developing insulin dependence is very, very high. In fact, if you have 2 or more of those in your blood, you already have type 1 diabetes. So that's something people don't understand. Right. If you have 2 or more of those autoantibodies in your blood, you already have type 1 diabetes. You may not be symptomatic, but you already have it.
Well, okay, so I know people who've gone through TrialNet and have had 2 or more of the antibodies and don't have, well, they have type 1, as you're saying, I guess, but they don't have the signs and symptoms. How is that?
So when we talk about populations and health, there's always people at the far end of the spectrum. Okay. Those people are at the far end of the spectrum. They don't represent what is normal for the whole population. There are a few people who have 2 or more autoantibodies who never become insulin dependent. There's also some people who don't have any autoantibodies who become insulin dependent, and that is type 1 diabetes. It just means that in those people, well, in the people with 2 or more who don't get insulin independence, there's some sort of protective mechanism going on there that I can't entirely explain right now. In the people who don't have these classic autoantibodies, it means they have something else in their blood that we're just not testing for.
Got it. Got it. I mean, I know the research isn't perfect and it's not, exact, but those things are important, which leads me to my next question, which is what happens when someone gets their results and they find out they do have these autoantibodies? What does the testing system do for them so they don't honestly get worried? And that's tough information to get if you're just home in your house opening a box.
Right. There's a couple things that happen through screening and a T1D diagnosis that can be scary. One, they're scary. They can cause a lot of psychological distress to the patient, their families. Also, some people get diagnosed with T1D in a really serious medical situation called diabetic ketoacidosis, which is in and of itself scary, and which in and of itself can cause worsened glucose control over the rest of your life. So there's a couple of things we're doing to mitigate all of these factors. First, we know that sometimes people get stressed out when they're thinking about getting screened for T1D risk or when they learn about T1D risk. And we're making it perfectly clear that there are healthcare providers at their disposal who they can talk to specifically for their mental health concerns around getting a risk diagnosis. Also, JDRF has specific volunteers who are trained in talking to people who have recently been diagnosed with T1D. They've been through it themselves. They can say what their journey was like, what is good, what is bad, what to worry about, what not to worry about. And that sort of personal communication, that sort of personal support is really important to help mitigate those stresses. And so we're going to deploy those same people to the people who get a risk assessment from our program.
So, and I really appreciate you going through this because you are a scientist. You are, you're kind of going above and beyond, I believe, talking about the mental health and the support here. But I think it's so important.
But that's science too.
Good point. So when I'm home, I get my envelope. It says you have these markers. Here's a phone number to call, or here are next
Someone's
steps?
going to call you.
Okay.
So first, you'll get your results. You actually will get an email from Enable saying your results are available. You'll have to log into the website to see your results. Now, Enable, the company, will know that you're in a high risk category. They will have a medical doctor call you to provide the results to you over the phone and talk to you over the phone. Then you'll start to receive a series of messaging campaigns directed to you, coming from JDRF saying, we understand what's happening. This is what we recommend you to do. A lot of the recommendations are follow up with your primary care physician. You probably should get a glucose test after this. We're giving all the recommendations that we know from our own experiences have helped. In the future, we'd like to see maybe a network of care around these people, but we don't have that yet. We don't have the ability to recommend a specific doctor to these people, but we can advise them to talk to their own doctor. We can support them through the JDRF network and give them the resources they need to make this journey as painless as possible.
I have to say, I am so glad to hear that you are not going to wait to be contacted by them, because that was my fear just looking at this as someone who's been through the process.
No.
When you get a diagnosis, you're not thinking straight at all. So I think it's great that you're going to be telling them.
We've done this before, right?
Yeah.
Part of the benefit that is JDRF is we're made up of people who have T1D, who've been through the diagnosis, who have a lot of experience and support to offer to new families. And so it's the least we can do in a program like this to offer that to a person just finding out that they're at risk.
You mentioned the 4 antibodies.
Yes.
Testing for 3. What's elusive about the 4th one?
The other one's called ZNT8, zinc transporter 8, and it's just a trickier protein to work with. So the assay that the company's using right now just doesn't have that sorted out yet, but they will have it, and they expect to have it in the next couple of months. It's not a big deal to not have it right now. We can almost definitively say, based on the results of this test, whether or not you'll become insulin dependent over the course of the next couple of years. ZNT8, the fourth one, just helps make that a little more sensitive.
Right. I just, didn't know, curious.
Yep. And it's just one of the things that we could add on going forward. Right now, we're focusing on autoantibodies, but there's other things that JDRF research is trying to develop that might improve our detection of risk in the population. Things like genetics, things like metabolic factors that we just haven't, the science isn't done yet. So in the future, you'll see things like that, I hope, being rolled into programs like ours.
So, when I was tested and I went through testing for TrialNet when I was young enough to go through testing for TrialNet, but I kind of did it just to see, right? We did not have type 1 in my family that I knew anything of. A couple of years later, one of my cousins was diagnosed at age 7 or 8, which was older than my son. But at the time, we knew nothing. But I never had my daughter tested because at the time, I looked at it as, well, if she's going to get it, I'm going to know the signs now. I wasn't worried about DKA or anything like that. But I wasn't thinking about the research aspect at all. Can you talk a little bit about why TrialNet or T1Detect, why these are important to look at, not just as, do I have it or not, but more of how can we prevent or treat type 1?
So that's a good question. So there's really, well, first, let me say that you speak about why you got tested, why you didn't test your daughter. A lot of T1D parents say that, well, I'm going to see the signs and symptoms of diabetes coming on before it gets so serious that my child's in a hospital. That's not always the case.
Right.
Now we see a lot of people saying that, but the science doesn't support that. So that's one thing. We're trying to prevent a serious hospital event that might occur at diagnosis. This is what TrialNet's doing. This is what other screening programs are doing. Second, there's a thought that there's nothing I can do if my child is found out to have early stages of type 1 diabetes because they have these autoantibodies. And that's not necessarily the case because, one, we know that there's really important monitoring that can be done in the hospital setting. A blood glucose test, something as simple as that could be done periodically, that could reduce very significantly the chances of that child having DKA. Also, insulin therapy can start earlier, because remember, just because you have autoantibodies and no symptoms, that doesn't mean you don't have T1D. You have T1D, and that means you're going to need insulin therapy sooner rather than later. So it really doesn't benefit people to wait on that. That's something to discuss with your endocrinologist, but starting that earlier actually is beneficial for all people at risk. Third, there are soon going to be ways, I hope, to intervene.
Yeah.
Next year, we may see the approval of the first therapy that can delay insulin dependence in people with type 1 diabetes, a drug called teplizumab from a company called Provention. That will be a really important first step in curing this disease and stopping it from occurring at all. And then to get at why would we screen more people? We know that developing new curative therapies for people with T1D, well, that depends on people participating in clinical trials. Mm. Now, I'm not saying we're doing this because we want to put people into clinical trials, but the fact of the matter is that programs like TrialNet and other screening programs here in the United States or in Europe are not identifying enough people to make these clinical trials go fast enough. That really slows down the development of new therapies for T1D. So one of the benefits of a program like this is to further increase the numbers of people who are aware of clinical trials. And we hope that that'll increase the development of new therapies. And also, pharmaceutical companies will start to see, whoa, there's actually a lot of people out there clamoring for, a lot more people clamoring for a treatment or a cure for this disease. Maybe we really need to be doing something about that. So it should get their attention pretty significantly.
why not from a JD, and I don't know if you can answer this. Again, you are on the science side, not on the public relations side,
Mhm.
but I'll ask. We've been talking about TrialNet this whole time. Why not just team up with TrialNet? But why not just team up with them? And they've been doing it. They're the ones that developed the trials for teplizumab and got it this far, right? Why try something new?
So what TrialNet does is amazing. What they've done over the last 30 years is amazing. They've charted the progression of T1D, and they've led to the development, I hope, of the first real therapies for T1D. So what we're doing is different. What we're doing is, I may have to think on this one, Stacey.
Take your time.
Yeah.
That's what editing's for.
So we want, TrialNet's a research study. And we could keep funding research studies till the cows come home and have not made any progress towards our goals of having autoantibody screening as part of normal preventative services, to have autoantibody screening as something that insurance companies will reimburse for. So what T1Detect we hope will do is force those changes into the US healthcare policies to incorporate that into normal preventative services. We're also not restricting our program to certain ages or to just family relationships. What TrialNet does great, it's a really important model to say, how can we find the most people the quickest who are at the highest risk of type 1 diabetes? And we know that people who have a family member, especially a first-degree family member that has type 1 diabetes, are at some of the highest risks in the population. So it's a really good way to quickly identify the most people you can, but it doesn't capture everyone. So we're not capturing adults. Almost 50% of people being diagnosed are adults, and we're not capturing that in programs like TrialNet. And almost 85% of people don't have a family member, so we're not capturing that in TrialNet. So by us doing something like T1Detect in parallel to TrialNet, we're trying a different tactic that will hopefully get us both to the same goal of increasing the numbers of people available for clinical trials, of changing clinical practice guidelines, things like that. And the fact of the matter is, the people we identify in our program are candidates for TrialNet. So we hopefully we'll be feeding that ecosystem as well with our program.
But it is, just to put a cap on it, it is different. It is distinctive. Yeah. The testing, I mean, even the TrialNet, the way that they test you is not a finger stick.
No.
So it's just a different process altogether.
It's a different process altogether.
Okay.
So we want to make sure that our test had a type of kit or assay that anyone could use,
right, that
you didn't have to be near a certain place for the test to be done, or you didn't have to wait too long for the thing to come in the mail. So there were certain, bullets that we had to, or boxes we had to check with our test that we thought were important for making it readily available to the most number of people as possible. And those were things like, it had to be a commercial style kit. It had to depend on a blood sample that was really, really small and really, really stable on that, on that cardboard piece of paper that's sitting on my floor. My dogs are walking over it, but it's okay because I can send it back and it'll be still fine. So there were a couple of things we wanted a couple boxes we wanted to tick there.
When I went through the website a little bit, I didn't go all the way through it.
Okay.
I am curious. I will probably order it, just to kind of see. Maybe I'll get my daughter to go this time. But I'm curious, what happens to the information? Am I signing and saying JDRF knows, this medical company knows? Talk to me a little bit, if you could, about the confidentiality.
Did you look closely enough at the bottom of the web pages?
Of course not.
Of course not.
So that's something. Terms and conditions?
Exactly. So that's something that's really important, right? Because what we're talking about now is people's personal and protected health information. It's a test result.
Yeah.
So we have to make sure that that is safe and secure, and that the person has choice in how that data is used. So you'll see at the bottom of the portal, there's certain disclosures, opt-in language. You have to agree to share your data with JDRF or the company Enable. We also have, if you read the terms and conditions, if you agree to share your data with JDRF, we agree to protect it. We won't let anyone else use it without your permission. We'll only use it to improve the program or to maybe facilitate future research studies, because the data that's going to come out of this is actually really important to see where people live and how old they are and what ethnicities they are as it relates to having autoantibodies. That's really valuable information for the research community. So we want to ensure that that data is available to them in a way that protects the person's rights. So pay attention to those little boxes at the bottom, but know that JDRF is working to ensure and will ensure that is used safely and to your best interest.
Well, and I'll give you an example. So in other words, I am great with research. Clinical scientists can have all my data. That's fine. And JDRF can have the data. But the last thing I want is for JDRF to say, hey, Stacy Sims wrote a book. And we're going to give Stacy all of this information from TrialNet because here's a whole new customer base for her. So
nope,
that's not going to happen.
We're not allowed to do that. No. Okay. If we were given that opportunity, Stacy, we would have to write to you and say, is it okay that we're sharing your data with Stacy Sims? And you'd have to say yes or no. And so we're making sure we can't do that without your permission.
You
and we
should
would never
share with Stacy Sims. She
never.
Very bad influence.
we know that already.
But I mean, all kidding aside, I'm really glad to hear that. That's one of the questions.
And this is like maybe JDRF's first foray into having access to what could be protected health information. So we have to make sure that the patient's rights are front and center and that that's protected in any way we can.
As we see the rollout of this, you mentioned we'll see social media, you're trying to appeal to more than the JDRF families, the families that are already at the walks and virtual events this year. What would be your ultimate goal? Personally, would you like to see this in pediatricians' offices in the next few years? Would you like to see it at, as you say, WebMD, check a box here? What are you hoping for?
So there's Frank personally, and then there's Dr. Frank who works for JDRF.
All right, let's start with Dr. Frank.
I actually would say both are the same goal. We really would like to see this as a normal part of preventative healthcare, so that when you're taking your child to a pediatrician's visit, they normally would get a blood test for something at age 2 or 3. We would like to see this included so that right off the bat, we know how many people in the United States and in the world are at risk for developing insulin dependence, so that we can intervene earlier into these people. We can improve their health right at the beginning. That holds true to children and adults. There's a lot of adults who are misdiagnosed with T2D, but they really have T1D. So we want to make this available to all doctors, not just pediatricians, and just become a standard part of healthcare.
Right. I have to ask about cost. I know you said that you are subsidizing. It's only $10 if people cannot pay the $50 or $55 you mentioned.
That's right.
That's still a barrier, isn't it? And is there a goal? You mentioned health insurance. Is it one of your goals to try to get that covered fully?
It is. So with our big goal, or my big goal, and JDRF's big goal of having this included in as standard care in preventative services worldwide, that includes reimbursement. So what I almost envision is sort of like an inflection point where JDRF and his partner should be able to float the cost of the test, and then eventually insurers will start reimbursing so that we sort of meet in the middle and costs won't be a barrier.
Yeah, I'm asking.
So that's going to take some time, Stacy. Yeah. That'll take some time, but it's right now people can take the receipt and try and get reimbursed for it. We really don't know how many companies will reimburse for this. And we're expecting that they'll have a lot of inquiries about this in the next couple of months. And we may have to have some phone calls with some of these insurance companies and deal with this issue. JDRF right now is working with our own insurer, the one that handles JDRF staff, to see if they can include this as a reimbursable test.
Yeah, because I'm gonna ask a question, and this is a tough one to ask, and I know it might be tough to answer. But without that, you're going to get a subset of people taking this test who are largely affluent, who are largely educated, better educated about diabetes, for certainly, who are perhaps mostly white, upper middle class, all of those things that we know we need more. We know we need more diversity in research and in diabetes. So I know it's important, but I felt like it's really important that we talk about that. Are you prepared for that first subset of people that you get to not be as diverse as you would hope?
We are. I'm not expecting it to be the case, but it could be the case. And so one of the benefits of this program is that we'll see the data. We're asking for demographics. We're looking for where people live. And if they offer it, they'll give us their general salary ranges, things like that. And we'll see how that matches up with who's getting the test. And then this program can pivot. We can then take that information and say, oh, we're not penetrating the right population. We're missing out on a subset of people who might be socioeconomically disadvantaged. We need to change the program to better target those people. And we can just turn, pivot, and do what we can to get at those people, because our goal is really access for everyone.
Yeah.
And so we will be consistently monitoring the program to see how we can best target these other populations.
And I imagine there were a lot of conversations inside JDRF, not just about the funding or the cost for the people taking the tests, but there's a lot of hard choices going on at JDRF right now in terms of what programs to fund. Before we wrap it up, why was this one more important than other programs and employees and chapters have merged? It's been a very difficult year. So to have something, I got to imagine this was really important to you all.
So yeah, it's super sensitive question. This has been a tough year for us. We lost staff, we lost revenue. We had to make some really significant, hard choices about what research we fund. Through all of that, screening has still maintained a major priority of the organization because it contributes to so many of our other programs that will accelerate disease-modifying therapies into people's hands. That being said, this particular program I mentioned before, it lives outside of the mission, lives outside of the research mission. It's more community engagement, patient education, things like that. We have a partner on this. So we have a corporate partner to help subsidize the cost of the program. And we're going to solicit, hopefully solicit support from other partners to make this sustainable in a way that it doesn't detract from our core mission of funding great research. So I do want people to be cognizant. This is slightly a separate program that JDRF manages, but it's really not impacting our bottom line of the fundraised dollars going to the best research. This is stuff that we're soliciting in addition specifically for this program. We wouldn't be able to do this without our corporate sponsors, the first of which is Provention. And we hope to add a couple more to the program in the next couple of months.
Yeah, that makes sense.
Yeah.
Was there anything that I missed that you wanted to talk about before I do wrap it up here? I mean, I feel better educated.
Well, I'm glad. Listen, Stacy, it's something that, this is a disruptive program. We know people have a lot of feelings about this, both good, bad, somewhere in the middle. If people have those feelings, have those questions, they should reach out to us. We're happy to hear them, to learn from them, and maybe improve or modify the program. And we're happy to answer any question. We have high hopes. We really hope that this will make some big changes for the lives of people with T1D. And it may not happen immediately, but it should start happening in the next couple of years. So we're excited, and we hope other people are excited about this too.
Great. Well, thank you so much for joining me to spend so much time and talk about this and explain it so well. And hopefully we can follow up and find out how it went in a couple of years.
A couple years, couple months.
All
Hopefully
right,
we'll
all
tell you
right.
some great things in a couple months. Thanks for taking the time to talk to me. And listen, if you or your listeners have any questions, send them our way.
You got it.
Yeah.